different, and we have to follow the issue of guidelines. So Professor Khurana, please give a
your guidance on
importance of all these 6 steps.
Thank you so much. It's really a pleasure to be here again, and I'm so glad we have a good
Already 106 have joined
today. Yes, it's really marvelous, and I wanted to inspire people today to understand that when we work and we do an ultrasound scan, we don't work at random. We follow a protocol, and it has been proved again and again that in daily practice, if you follow a protocol, then your results will be far superior than if you just do things at random and you don't make a conscious effort to follow the steps that are written out in protocols. We have several protocols to choose from for any particular one, because almost every academic society in the world has a protocol, but there are some which have stood the test of time, and some which are actually compromised protocols. Now, all of us, including Professor Shama Kanongo and Dr. Hasmukh Lal, and all of us believe that we should not follow protocols that are compromised protocols and are based on the fact that you can afford to skip 1 or 2 steps. It does not work out correctly. These are already simplified protocols and give you minimum standards. So what we're going to hear of today is the minimum standard, and we must follow these. Sometimes it may not be possible to follow step by step, that not step 1, step 2, step 3. But you must make sure that at the end of it, you have done these steps. So I'm looking forward to today's talk, and we will talk more about it after the presentation is over.
Thank you.
Now, I request Ajit to share screen. Ajit sir is a marvelous teacher par excellence. He was a brilliant student who passed out from his post-graduation from JIPMER, which gives a very good background to teaching and clinical expertise. And he has a lot of, he's FICOG, and he has covered at assistant professor. He did postgraduate diploma in MCH from IGNOU, and I was so happy as that a teacher, because whatever courses you do, you learn something from it. And he has a lot of, he did a course in genetics, and then in ultrasound he has taken a basic training, and then he is now a trainer in the 6 months course as well as the 7-day hand holdings, the confidence building training that we have at SCB, and specialists come down. So he is in charge of that training, and he's got a very clear concept. And I request Ajit to start his presentation, and all of you listen very, very carefully. And in the post polls, you will be able to answer all the questions if you follow very carefully. Don't disturb those who join. Please immediately mute your set so that we can hear Ajit. Okay, Ajit sir.
Good afternoon, everybody.
Laptop nahi ki?
I'm in the laptop. Laptop records.
Okay. Kichu bhi voice asuni mane discussion kichu subun.
Hello, most
Subuchi sir, Subuchi.
Good afternoon, everybody. At the outset, I express my deep gratitude to Professor Shama Kanongo, Dr. Hasmukh Lal sir, Dr. Ashok Khurana, who is the president of SFM, all the esteemed gynec specialists of the states, all the participants who have joined this online training on basic ultrasound. So as we know, ultrasound is the watchdog of pregnancy. Simple clinical examination of the abdomen will not solve the problem unless we do a basic ultrasound. So today topic is the 6-step approach, and as told by Dr. Ashok Khurana sir, this International Society of Ultrasound in Obstetrics and Gynecology, this society recommends certain principles and we have to follow. We cannot blindly do the survey scan, and we cannot comment on different parameters of the fetus like the lie, presentation, number of the fetus, cardiac activity, and the fetal environments, which include the placental localization and placental position.
Your slides are not moving.
It will move, sir.
Okay.
And of course, the amniotic fluid index. So at the end of the lecture, we should be able to explain how to assess the fetal lie and presentation, the fetal environment, that is placenta, its localization and position, and about the amniotic fluid volume. So what should be the sequence of the probe or the transducer moment required to diagnose or to comment on the lie of the fetus, the presentation of the fetus, the number of the fetus, whether it is a singleton or multifetal gestation, the placental site, localization, its position, and of course, most important is the amniotic fluid volume. So this probe moment we should learn in this session. As we know, unlike routine gynec abdomen ultrasound, the obstetric ultrasound itself is associated with its inherent difficulties. Number one, it is operator dependent procedure. Unlike in CT scan or MRI, the technician will capture the image and the next day the radiologist will interpret on the CT scan MRI. But here we have to do the live interpretation while doing the ultrasound. So definitely the dependency of the operator is very crucial, and operators should be well trained. And as we know, the fetal organ anatomy is a very complex one. So unless we understand the basic embryology and basic anatomy of the fetal organs, it will be difficult for the sonologist or radiologist to perform an obstetric ultrasound. And of course, because the movement of the fetus, sometimes we want to capture the image, it will be very difficult. And sometimes while doing the Doppler study also, it's very difficult to put the gate over the target vessels. And another thing is due to the shadowing of the target anatomical regions, which hampers clear-cut visual of the anatomical organ which is supposed to be imaged. And last but not least is the maternal body habitus. That means if mother is obese, having high BMI, that will prevent good images. So then this training what we are doing, it enhances so of course it minimizes the ultrasound steps. So haphazardly we are doing so many steps. So after this training, we should be pinpointed which step we will do, which step we are not going to do. It introduces consistency in image acquisition and interpretation of the result, and allows for efficient examination, and of course it shortens the learning curve of the training, and it provides path to automation. That means after this training, somebody can do himself or herself the ultrasound confidently. So these are the parameters to be examined while doing a basic obstetric ultrasound, which is recommended by Dr. Abu Hamad, as we know, and we are going through his recommendations. So number one step is the determination of the fetal presentation and the lie of the fetus. Next step should be detection of the fetal cardiac activity. Step 3 is to identify whether it is a singleton pregnancy or it is a multifetal gestation. Fourth step is the localization and position of the placenta. And fifth step is the estimation of the amniotic fluid. And step 6 constitute the standard fetal biometric measurements, particularly BPD, head circumference, abdominal circumference, and fetal femoral length. These are the 4 parameters we do in second and third trimester obstetric ultrasound biometric assessment. So this is the ICOG Education Committee recommendation for basic training in obstetric ultrasound. So these are the informations to be obtained at most basic obstetric ultrasound scans, which is the topic of tomorrow. And this is the checklist for basic obstetric ultrasound. As already I told, we should know the fetal viability by looking for the fetal heart and fetal movements. And we should know the number of the fetus, whether it is a singleton or multiple pregnancy. And of course, we have to assess the gestational age, and we have to compare the biometric values with gestational age, and accordingly we can estimate the fetal weight, and we can diagnose whether there is macrosomia or there is fetal growth restriction. And assessment of the fetal size by recording the various biometric measurements, and we can measure the FL by SC ratio, by which we can diagnose whether it is a fetal growth restriction or it is a macrosomic baby. And descriptive evaluation of the amniotic fluid, which is a very important component of the fetal biophysical scoring. And of course, we have to evaluate the placenta in terms of its position, its location, and of course grading, and the fetal lie and the fetal presentations. This is the committee recommendations by ICOG. Next slide is the step 1. In step 1, we are looking for the fetal lie and the fetal presentation. As we know, to diagnose the fetal lie and fetal position, the placement of the transducer of the, or the probe is very important. So while commenting on the fetal lie or the fetal presentation, as shown in the picture, the transducer is placed transversely in the lower abdomen, just above the symphysis pubis. So it should not be oblique, it should not be perpendicular, it has to be placed transversely. That is the recommendations. And this picture was taken from the patient's left side, and the dotted line here represents the initial position and orientation of the probe. So we have to follow this step 1 while performing ultrasound to know the fetal lie and fetal presentation. This is the next picture. After placing the probe transversely above the symphysis, above the lower abdomen, just above the pubis symphysis, we have to tilt the probe little up and down to know the presentation and lie of the fetus. As we know, the lie can be transverse, the lie can be longitudinal. So in longitudinal lie, it can be a cephalic presentation or it can be a breech presentation. And in transverse lie, as we know, the lower pole is empty. So this is the picture where it's a cephalic presentation, and here the head of the skull is inside the lower pole of the uterus, and we can see the fetal head, and the diagnosis is cephalic presentations. The next slide is a slide showing breech presentation. We are seeing the lower pole of the uterus is the bottom part is seen, hence it is a case of a breech presentation. So from the step 1, we are able to know the presentation and lie of the part. And these next slides, we are seeing the lower pole of the uterus. This is the lower pole of the uterus is empty. And here also the lower pole of the uterus empty. And the fetus is lying transversely, extending from one flank of the maternal abdomen to another flank of the maternal abdomen, and head is in one side and the buttock or the bridge part is on the opposite side. And this is the dorsal position, and this is the ventral position of the transverse line. So from the transverse line also we can know whether it is a dorsal or whether it is a ventral. This picture clearly showing the line of the fetus from the initial step 1 procedure. So these are the pictures. First one is the cephalic presentation. The second one is the bridge, and the third one is the transverse line. Coming to the step 2 is the detection of the cardiac activity. So what we do to find out the cardiac activity, the transducer or the probe again placed transversely in the lower abdomen just above the symphysis pubis, and this transducer is moved mid-abdomen towards the umbilicus. So from the symphysis pubis, the transducer is moved towards the umbilicus while maintaining the transverse orientation of the ultrasound probe. So the transverse orientation of the probe has to be maintained while locating the cardiac activity. If fetal cardiac activity is not seen in this step 1 of this procedure, then we have to move the transducer from the umbilicus, to either left side or right side. So we have to move the transducer from either to the left side or the right side of the abdomen, and the transverse orientation of the probe has to be maintained throughout these steps in step 2 while detecting the fetal cardiac activity. This is all about detection of the cardiac activity, that is step 2. Next, so this is the initial orientation of the probe in step 2. Then these are the various movements from the symphysis to the umbilicus. If you are not seeing the fetal heart, again we are moving it either to the left side of the abdomen or right side of the abdomen to look at the fetal heart. This is the fourth chamber view of the heart, which is a very essential component which will be discussed later on in fetal echo or something else. And this fourth chamber view is important because to trace the fetal heart or to know the fetal heart rate, we have to put the M mode over the valve so that nice wave will come, and by seeing the wave and measuring the wave, we can measure the fetal heart and to diagnose whether there is a fetal bradycardia or fetal tachycardia. And as we know, normal fetal heart is 110 to 160 per minute. So this is the M mode. So first we have to locate the heart and we try to find out the fourth chamber view of the heart. Then we put the M mode cursor over the valve of the heart and we are getting the waves, these waves. So some ultrasound machines are set up where to measure the heart rate, we have to one peak of the wave to another peak of the wave as shown here. But in some machine, we have to skip one wave to know the exact fetal heart rate of that patient. So this is the M mode interpretation to know the fetal heart rate. This is about the step 2. Now coming to the step 3, which is very important to know the number of the fetus. So again, we have to see how the probe should be moved and what will be the orientation of the probe. Here, the transverse transducer moment for determining the number of the fetus. Again, the transducer moment is transverse, and these are not that. The uterine cavity is scanned from symphysis pubis towards the patient head, from symphysis pubis to the patient head, from symphysis pubis to the patient's head, from the symphysis pubis to the upper abdomen. So the uterine cavity is scanned from symphysis to the patient's head along the track 1, 2, 3. So track 1 from symphysis to upper part of the abdomen, track 2 again from symphysis to the upper part of the abdomen, and track 3 again from the symphysis pubis to the upper part of the abdomen. If we do like this and put the probe with the transducer in the horizontal direction, then we transverse direction, then we will not miss any fetus. Sometimes if you don't do or follow the procedure correctly as described here, we may miss sometimes multiple pregnancy and we may land up in medical legal problem. So as shown here, these are the dotted lines that represents the initial position and orientation of the probe in each maneuver. So this step has to be strictly followed to rule out any multifetal gestation or pregnancy. So this is again, they are vividly describing how to move the probe. The sagittal placement in the right upper abdomen. So this is the right side, this is the left side. This is the sagittal placement of the probe in the right upper abdomen and perpendicular orientation of the transducer to the floor. And this probe or the transducer should be perpendicular to the floor or perpendicular to the maternal spine. That's very important. And the transducer is moved from right to left. This is the right side of the abdomen. This is the left side of the abdomen. And transducer will move from the right to the left along track 1 and again from right to left along the track 2. And this orientation of the probe has to be perpendicular to the floor. So this probe orientation is perpendicular to the floor. And the moment, as I already told, it's initially from the symphysis to the upper abdomen. And next step, if we are not able to diagnose, we can move the probe from left to right, from left to right. So this is the picture. This is the case of a single-daughter pregnancy, and this is a case of twin pregnancy where both are cephalic. And if it is a twin pregnancy and we follow this step, sometimes also we may not miss a case of conjoined twin, because chance of missing a conjoined twin is also very important. If we follow strictly this principle, we may not miss a conjoined twin also. Now come the step 4. So step 4 is about the placental localizations. Here, the sagittal transducers, the transducer is placed sagittally. The moment is very important to locate the placenta. This is the uterine cavity scan from the fundus. So all these steps was from the symphysis to fundus, but while localizing the placenta, this transducer has to be moved from the fundus to the symphysis pubis. This principle has to be strictly followed, and this probe should be perpendicular to the floor. This probe is perpendicular to the floor or the maternal abdomen, maternal spine, and the probe movement is from the fundus of the uterus to the lower pole or symphysis pubis. And this is the track we should follow. This is the track 1 from the fundus of the uterus to the lower pole. Track 2 again from the fundus of the uterus to the lower pole, again from the fundus of the uterus to the lower pole. So the dotted line, these are the dotted line that represents the initial position of the probe. This is the initial position of the probe and orientation of the probe for each maneuver. This is about placental localization. Again, they are describing how to move the probe. This is the initial orientation of the probe, and these are the picture figures where the probe will be subsequently moved to exactly locate the placenta where it is. As we know, placental localization depends upon the lower edge of the placenta, how much distance it is from the internal solid.
Hello? Ajit, are you muted? Hello, Ajit?
He lost contact. I think ताकर इंटरनेट टा बोधे डिस्टर्ब होउची. Hello, Ajit sir.
Ajit sir, Ajit, please rejoin.
Madam, maybe internet connection problem.
I'll recall him.
संबित बाबू आपनकर पाखरे अछि तांकर स्लाइड्स
आगे आज
के लोड कर दो नांती
आगे हम कर दो
तांकर बोले इंटरनेट पाई कटि गला एटा तांकर
कॉल करछु कॉल करछु
150 करोड़ कोविड टीकाकरण की दिल्ली मिसाल उपलब्धि हासिल की है। अपना टीकाकरण अवश्य पूर्ण करें।
Sambit, you can share screen so that either Hasmukh sir or myself we can. Hello. Oh, Ajit is trying to join. He's trying to join.
So basically, in the meantime, let me tell you, these slides actually are ISOG slides, and they, because ISOG has an outreach program, I mean, they start teaching to the lot of trainees world over. So Professor Abu Hamad, his wife Sharon Abu Hamad, and Elena Sinkoskaya. Elena Sinkoskaya and Abu Hamad, they had a paper which Elena is a fellow of Dr. Abu Hamad, who is a professor and dean in the University of Eastern Virginia. And they found out that those fetuses who have cardiac axis is abnormal. 72% of cardiac heart defects will have. Okay, Ajit sir, go ahead. Yeah.
Yes, Ajit, unmute yourself.
Right.
I think you are.
madam.
Go ahead. Yeah. Slide.
Is it visible, sir?
Yes,
It is
visible,
visible,
but I
but
think you
I
go
think you are.
before.
This is your next slide. This is the previous.
Next slide is about
Yeah.
Yes. From there. No, before that.
Yeah, before this.
Step 4.
So placental localization, again, I have to repeat. I think it was.
No, you have gone
So
to amniotic
step
fluid.
4 is about the. So, madam, placental localization, I think it's over, or you have not seen, madam.
Yeah, you start right from the beginning. Yes.
So localization of the placenta.
You were saying that you start from
is
fundus
very
downward.
important. Yes, madam. So we have to move the probe. We have to move the probe from the fundus to the symphysis pubis. So this is the fundus of the uterus. This is the symphysis pubis. And these are the dotted line where the probe is placed, that is perpendicular to the floor. Perpendicular to the floor. And this is the track 1. Once track 1 is completed, we have to go to the track
And
2.
the probe
And this is
is
the
sagittally
track
placed.
3.
Unlike other
Yes, ma'am.
steps, this probe is sagittally placed.
So the probe is sagittally placed. And so this is the again. So this is the initial position or the placement of the probe in the one side of the fundus, then this probe is moved to the upper part of the symphysis pubis. Again, this probe is moved from the mid portion of the fundus to the lower portion of the symphysis pubis. Again, probe is moved from the one portion of the fundus to the lower segment. But if we follow this method, we can diagnose the location of the placenta in relation to the internal loss of service. Of course, to diagnose the placenta previa, we have to go for a TB scan. TB scan is the gold standard to diagnose the low-lying placenta and placenta previa. Anyhow, the location and positioning of the placenta is the step 4. And here, these are the various pictures where the placenta, here the placenta is located in the fundus. Here the placenta is anterior, and this is very close to the sockets. And this is the picture, graphical representation of various location of the placenta: anterior, this is the posterior, this is the fundal, and this is the low line. Low line means if the placental lower margin or the edge of the placenta is within 2 centimeters the internal loss, then it's called low line placenta. If the placenta is touching the internal loss or it is covering the internal loss, then it is a clear case of placenta previa. So this picture shows a clear case of placenta previa where the placenta is sitting over the internal loss of the cervix. And this placental thickness and placental grading will be taught, I think, later on. It is taught in this purview. So I'm not going to talk about the grading and the placental thickness. The next slide will be on the estimation of the amniotic fluid. So as we know, very important parameter of the placental function, and amniotic fluid estimation can be done by subjective and objective assessment. Here we are doing objective assessment. That means we have amniotic volume in terms of the amniotic fluid index AFI or single deep vertical pocket that has to be measured. So this is the placement of the we divide the maternal abdomen into 4 quadrants: right upper quadrant, right lower quadrant, then again left upper quadrant and the left lower quadrant. So here they have started. This is the right upper quadrant. This is the left upper quadrant, and this is the right lower quadrant, and this is the left lower quadrant. So initially they have put the probe or transducer in sagittal orientation and perpendicular to the floor. So the side should be sagittal and perpendicular to the floor. And here, this is the first quadrant, quadrant number 1, and we can measure the amniotic fluid in centimeter. Again, we do the same maneuver in quadrant number 2, that is left upper quadrant. We put the probe again perpendicular to the maternal floor, and the probe is sagittal in orientation. So the
I think Tankara internet is very unstable. Yeah.
I think it is visible now. Is it visible now?
No, your slide disappeared. Apnar slide guda chali gala सब.
You have to share screen once more.
Sir, I can. Is it visible now, madam?
No, not yet.
Share screen. You have gone out. You have stopped sharing.
Screen share कर दे भी अपना next करके चल.
I think that would be
I am
better.
doing it. Is it visible now?
No,
No, not yet.
Is it
It's not
visible, sir, madam?
it's not
No, it's
visible.
not visible.
We can see
Not
but not the
visible.
slides.
Not visible.
I think some network problem like the other day with Jyotsna madams. Whole thing became black. So now we can see. Yes, now we can see Ajit.
Madam?
Yes, we can see now.
Yeah, madam. Thank you.
Estimation of amniotic.
So this is we divide the abdomen into 4 quadrants, and this is the quadrant 1 where we put the probe perpendicular to the maternal abdomen, and this is the sagittal position of the probe. So quadrant 1 we measure in centimeter. Again, this is quadrant 2. We measure the amniotic fluid pocket in centimeter. This is the quadrant 3. The probe maneuver and the probe position is the same throughout while measuring the quadrants. This is quadrant 4, and we can sum quadrant 1 what is the fluid, and quadrant 2 what is the fluid, quadrant 3 what is the fluid, quadrant 4 what is the fluid, and we can sum it, and we can ultimately get the amniotic fluid index. This is called 4-quadrant method, which routinely these ICOG people they are following the 4-quadrant methods, and these are the dotted line that represents the position and orientation of the probe while scanning the 4 different quadrants. That means they have to start from this is the 1, and this is the, again they have to go to 2, then 3, then 4, and this principle has to be followed throughout. And this is the single pocket method where we can measure a single deepest vertical pocket, and inside this pocket there should not be any cord, or there should not be any fetal extremities or limb or fetal part. That means it should be a cord free and extremity free clear pocket, and it should be measured in centimeters in all the quadrant. If we are seeing any cord in the pocket, or if we are seeing any limb in the pocket, that pocket has to be excluded from estimation of the amniotic fluid index in 4-quadrant method. And while measuring the AFI, as I already told, the probe should be perpendicular. Is it visible, sir?
No.
ଆପଣଙ୍କର synchronous ହଉ ନାହିଁ, ମାନେ what you are telling and the slide ଯୋଉଟା ଆପଣ ଦେଖଉଛନ୍ତି, they are not matching.
Yeah. Estimation of
now I am showing the slide about AFI measurement technique.
No, it is not there. ଆପଣଙ୍କର it is held up at 4 quadrants showing the maternal abdomen.
You are here now, sir.
ଆପଣ next ku jaantu, go to the next.
Next. The slide is visible, sir.
Not moving. Your slide is not moving. It is held up at one particular place where it is step 5 showing maternal abdomen and
Figure 6.
Yeah.
Sir, maybe आपनकर वीडियो जेतु ऑन अछि सेत पे टिके डाटा कंजप्शन टिके स्लो अछि सर वीडियो ऑफ कर देले मे भी
I think you might get better connectivity. Switch off your video and keep only the slide moving. That might improve
So this is the 4-quadrant I already discussed, and this is the technique where we have to strictly follow. The probe will be perpendicular to the maternal cloth. It should be sagittal in position. 4-quadrant, we have to take the amniotic pocket, and we have to sum up. And this is the pocket where we are seeing it is free of any cord or free of any limbs or extremities, and this is the single deepest vertical pocket. This diameter has to be taken. It should not be any oblique diameter, or it should not be transverse diameter. So deepest vertical pocket. This line is very important. Deepest vertical pocket has to be measured. And this is the wrong technique. This is the correct technique. Visible. The probe is perpendicular.
That slide is not visible.
Still not visible, sir. That. I made video, it's off, still not visible.
We can see. I can see.
No, slide is
measurement we can see.
Now slides are moving according to the speech.
Yes, moving.
Yes, visible. Ajit, continue.
Thank you, madam. So this is the correct positioning of probe, and this is the incorrect positioning of the probe. And if you give too much pressure, then we can underestimate the amniotic fluid. That's very important. As we know, the normal amount of amniotic fluid is 5 to 25 centimeter. And some people, they say it is 8 to 18 centimeter. And if it is from 5 to 8 centimeter, then it's called reduced liquor. And less than 5 centimeter, it is oligohydramnios. 25 centimeter, it is excess liquor. And more than 25 centimeter, it is polyhydramnios. And this is the picture where these quadrants are measured. This is the quadrant 1, this is the quadrant 2, this is the quadrant 3, and this is the quadrant 4. And these all 4 quadrants pockets are summed up, and ultimately we get the amniotic fluid index or AFI. And now coming to step 6, that is the fetal biometry. And among the fetal biometries, most important is the bioperital diameter, or in the first step. Next step is the head
We can't see the
circumference
biometry.
measurement.
We
Then
can't see biometry. Please.
Step
Those
6.
slides are lagging behind.
Now I am in the step 6, madam, biometry.
You go to that step 6. In your slide.
It is my slide. In my laptop, it is one of step 6 biometry.
But here we can see something else. Still further. Go down. Step 6 we cannot see. Now we can see. Now step 6 has come.
Yes,
Yes.
madam.
Yes.
So step 6, everybody knows, in the second and third trimester, we measure the biparital diameter, we measure the head circumference, abdominal circumference, and femoral length. And the initial step is the biparital diameter measurement. This is the picture showing the biparital diameter measurement. And while measuring the biparital diameter, or BPD, we have, this is also called transthalamic plane or BPD plane. So the correct BPD plane is that the fetal head is ovoid in size, and the interhemispheric fissure should be seen or visible, and there will be a gap between the midline falx and thalamus. So there will be a echo-free area between the midline falx and the cavum septum, pellucidum, and thalamus, and with parallel walls.
No,
seen
please
in the
keep
midline.
keep the slide there static when you're describing the thalamic plane. Transthalamic plane.
This is
Show the transthalamic plane and stick there before after until you complete. Okay.
So this is
Okay,
the BPD plane. This is BPD plane or transthalamic plane, and this is the midline falx or interhemispheric fissure, and this is the echo-free area, or there is a gap between the fissure. This is the cavum septum pellucidum, and this is the thalamus, and this is the midline falx is continuing, and these are the ventricles. So this is the line, and this thalamus is projecting towards the cerebrum, and this is there is a, and this arrow sign suggestive of proper transthalamic or proper BPD plane. That means in the BPD plane, we supposed to see the midline falx, we supposed to see the space between the midline falx and the cavum septum pellucidum, and thalamus should be well seen on both sides of the midline or both sides of the third ventricle, and this thalamus with cavum septum pellucidum should make an arrow posterior fossa, and this is called the arrow sign, which is the proper thalamic plane or the BPD plane. And while measuring the BPD plane, we have to measure from the outer table of the skull to the inner table of the skull. So outer table to inner table is important to measure the BPD. So this is the detailed description. The fetus head should be ovoid, and we should see the midline falx. The midline is there, between the falx and the cavum septum pallidum. Aerosign should be present and measurement should be taken at the base of the thalamus from outer table to inner table, and the plane should be perpendicular to the midline. So this is the graphical representation. This is the midline falx, and these are the cavum septum pallidum. These are the thalamus, and these are the falx cerebri, and these are the choroid plexus inside the lateral ventricle of the brain. So this is clear picture of a aerosign, and this is the measurement from the outer table of the skull, proximal skull, to the inner table of the distal skull. It's not from outer to outer, it is from outer table to the inner table. That's to be remembered. And aerosign should be seen in the BPD or the thalamic plane. I think everybody can understand what are the things to be seen in the BPD plane. So this is the thalamus, and these are the two parallel lines in the midline. These are called the cavum septum pallidum. And if we are seeing the cavum septum pallidum, that means hollow prosencephaly is excluded. So cavum septum pallidum identification is also very important in the thalamic plane to rule out any hollow prosencephaly. So this is about the cephalic index. In cephalic index, it indicates the ovality of the fetal head, and as we know, the cephalic index is the biparietal diameter divided by the occipitofrontal diameter into 100. The normal range of the cephalic index is 75 to 85%, and the mean value is 78%. The cephalic index, if it is less than 75, it is a dolichocephalic head, and if the index is more than 85, is brachycephalic. And if so, what is the importance of the cephalic index? If cephalic index is less than 75% or it is more than 85%, the BPD estimation is less reliable. Then we have to go for the corrected BPD measurement. So that's why we have to find out the cephalic index, not only to diagnose whether it is a dolichocephalic or brachycephalic, but also to diagnose what is the corrected BPD. So what corrected BPD? The corrected BPD is required to overcome the different skull size and variability of the BPD, particularly in case of overcrowding of the uterus due to leaking, overcrowding of the uterus due to multiple pregnancy, or there is a breech presentation, skull cell may deranged. So what do we do in corrected BPD? We calculate it by square root of BPD into occipitofrontal diameter divided by 1.265. This is about corrected BPD. And once the BPD is corrected, then it is equivalent to the head circumference. And this is about the importance of the corrected BPD. And the head circumference plane, we have measured the head circumference where this everything will be covered, and it is from outer table of the skull to the outer table of the skull. This is the occipitofrontal diameter, and this is the BPD diameter. Again, from outer table of the skull to the outer table. In AC, we have to measure from outer table to outer table. Here also outer table to outer table. Nowadays, because of the eclipse method, the computer itself will generate the head circumference by measuring BPD and occipitofrontal diameter. That method is done. Now automated machines are come. They will show the head circumference directly in the computer. Now coming to the abdominal circumference. By measuring the abdominal circumference, it should be as round as possible, and this visualized ribs should be symmetrical, and we should measure the AC with umbilical portion of the left portal vein in the abdomen, and both the umbilical vein and portal sinus are seen and form J-shaped. This is called hockey stick sign. So arrow sign.
Again, you have gone out, Ajit.
I think Sambit now should have shared the slide. And That would have been better.
Is it visible now, sir?
No, not.
AC
Now
plane,
it's visible.
AC plane is visible.
Yes, yes.
I
Now,
mean, the AC
now it is visible. Ajit, continue.
Okay, madam, thank you. So it should be as round as possible, and this visualized portion of the ribs should be symmetrical. It should be measured at the level of liver. Both the umbilical vein and the pectoral sinus are visible and they form a J shape. This is called the hockey stick sign. So hockey stick sign in the AC plane and arrow sign in the BPD plane. And the stomach ideally should be visible. Fetal kidneys and fetal urinary bladder we should not see in the AC plane. We are seeing the fetal kidneys. It is not a proper AC plane. And we have to measure the outer perimeter, that is outer to outer, to include the subcutaneous tissue. And while measuring the AC, avoid excess probe pressure. And we can calculate the AC by measuring two diameters D1 into D1 plus D2 into 1.57. But now the message automatically showing the estimation of the VPD. So this is the AC plane. We are seeing this is the stomach, this is the J or hockey stick sign. This is the umbilical vein and this is the left portal vein. This left portal vein should be short, it should not be too long. And the umbilical vein should be long and the left portal vein should be small or as small as possible you should see, and that will make a hockey stick sign or J shape. So if we are seeing a hockey stick sign or J shape, umbilical vein and portal vein alignment and stomach shadow, and this is as round as possible, then it is a proper AC plane. So here this is the stomach shadow, and this is the vertebra, this is the aorta, and this is the hockey stick sign, this is the umbilical vein, this is the left portal vein, making J shape. And so AC may be affected if
Just one point, Ajit sir. Okay.
So AC measurement may be affected if breathing activity, if there is a compression by the transducer, or if the uterus is crowded due to leaking, due to multiple pregnancy, or in case of breech presentation, or if you find in any discrepancy while estimating the AC, you have to measure the AC multiple times and take an average, because AC has the largest reported variability and more affected by fetal growth. So this thing has to be kept in mind while measuring the abdominal circumference. Again, showing this correct plane of the AC, because among all the fetal biopsy, measurement of the abdominal circumference to get the AC plane is very difficult. That's why we should strictly follow this principle. It should be as round as possible, stomach should be seen, and J-shaped thing or hockey stick sign should be visible. This is the incorrect AC plane where stomach is not seen and there is no hockey stick sign, and the liver and hepatic cells also not properly, liver portion is not properly included. So this is the improper AC plane.
Dr. Ajit, please, Ajit, just 1 minute. Please, everybody, just see next to the crura diaphragm, instead of the kidneys, you can see the adrenals, which appear like rice grain. Just next to the spine, next to the crura diaphragm on both sides. Okay.
Actually, that
because the picture is there, one should see just next to the crura diaphragm, instead where the kidney should be there on paraspinally, you can see the adrenals, right? This Suresh have taught us rice grain like appearance.
Yes, madam. Thank you, madam. Important point. We should note it.
Yes, go ahead.
Okay, madam. So next is the femoral length. So while measuring the femoral length, we should measure the aphysis only. We should not measure the epiphysis. So while measuring the aphysis is clearly visible. This line is very important. The both end of this one end of the metaphysis and this is the other end of the metaphysis. This ossified end should be clearly visible. Then only we can properly measure the femoral length. The cartilage at the end of the femur, that is called the epiphysis, should not be included while measuring the FL, and any artifact like spur artifact has to be excluded, and we have to measure the longest axis. And it can be either parallel, that is 0 degree to 14 degrees expected, and more than 14 degrees is not allowed while measuring the femoral length. And this is the correct, this is the bony spur, and this bony spur should not be included by measuring the femoral length. Only the diaphysis portion is included, not the bony spur, nor the epiphysis. And here again, the distal femoral epiphysis is excluded from the measurement of the femoral length. Here also, this is the epiphysis, this is the epiphysis. They are not included in the femoral length measurement. So this is about this obstetric ultrasound examination. If you do it in the proper steps, how much time is required? If you don't do in proper step, how much time is required? And the significance in terms of the p-value they have mentioned. Regarding the number of the fetus, we follow all this protocol in the second trimester and third trimester. Then p-value is not, p-value is significant, and the cardiac activity estimation, p-value is not significant if we follow the procedure in second or third trimester. So this is about the statistical analysis of the procedure, and this is about the video link. If somebody wants to see what Dr. Abu Ahmad has told regarding the 6 steps very clearly, we can go through the video link and we can see the detail of what I described, the 6 steps. So the ultrasound examination in the second and third trimester should be approached systematically as per the 6 steps
Dr.
approach.
Hasmukh, do you have the video link?
Video link actually what
Anyway, let Ajit continue.
yeah, actually this is there on the in the ISOG site. Yes,
Yes, sir, it is there in the site. Everybody can see the site, no problem.
everybody can see.
Thank you, sir. So the sequence, as I already told, step 1 is the fetal presentation, step 2 is the cardiac activity, step 3 is the number of the fetus, step 4 is the placental position, step 5 is the amniotic fluid volume estimation, and step 6 is the biometry. Step 1 to step 6 has to be strictly followed in sequence. And this standardization of technique of the steps enhance the confidence in the trainees, will not miss anything abnormal. That's very important thing. Thank you all for your presence sharing. Thank you again to Professor Sahanango Madam, Dr. Hasmukh Lal sir, and Professor Khurana sir.
Ajit sir, आपण से previous slide गुड़ा को देखंतु. Take one previous slide.
Sir.
Where the p value was there. Yeah, show me that slide.
Yeah. Yes, sir. I think, sir, you can interpret better.
2 slides back.
Slides back. Yeah. Just keep it here. Just keep it here. No, other one. After this.
The standardization slide.
Yeah. You keep it there. See, basically, what Ajit sir has been insisting all the time is keep the transducer 90 degree to the floor, perpendicular to the floor. You know, we learned in physics that any sound waves we are sending, and if we send it to 90 degree perpendicular, every returning sound, every returning signal will be maximum. For beginners, we are insisting in 6-step approach, every movement, transducer movement is keep the transducer perpendicular to the ground, because you will have maximum information. Now the second point is if we follow a systematic approach like the 6 steps approach, the time taken to complete a scan will be minimal, and there will be, you know, if you are, all of you are gynecologists, with minimum steps, if you do a surgery, you are perfect. So if minimum steps you use to complete an ultrasound, you are an expert in the ultrasound. Ashok sir is an expert. You should see him performing a scan in, I believe that in 9.5 minutes, he will complete the whole anatomy scan. You know, if you watch him sometimes, maybe we will be lucky when in the conference, when he is demonstrating. So first thing was as I said, keep the transducer perpendicular. It is very, don't tilt it, don't angle it. You can angle it in the symphysis pubis to look at the head, whether head is there or it is not there. Now, the third point I would like to see, we have got a lot of information. This whole course is designed in such a way, many things will come back again and again. Like our next, today Ajit sir has included biometry because we thought that, okay, this topic is very short, so he could include. But again, next lecture, Dr. Josna Panigrahi is elaborating on fetal biometry. So you will have, don't get frustrated if you missed something or you haven't heard something. See, and as far as Dr. Ajit said about grading of placenta, we are not grading placenta these days because of the importance of the Doppler, you know, because we are able to measure placental function, and that's the one of the reason the grading is just an observational study, whereas the Doppler studies give you a 100% functional study. It tells you about how things are going on in detail. That's why grading we are no more grading placenta these days. And of course, placenta and grading, placenta and amniotic fluid, again, it will be discussed very elaborately by Dr. Pramodini Swai so things will come again and again. You will have a lot of chance to learn things again and again. And many of this, like this book, this standardization thing, and this whole 6 steps approach has been designed by Professor Abu Hamad. And see here it says time in seconds to complete each step of standardized 6-step approach to the ultrasound examination in the second and third. This is in seconds. So if you follow a protocol, see how much less, I mean, in seconds you are able to complete some steps. Some steps will take time, like biometry would be a little challenging. And the other number of fetuses sometimes, but still it is not very high. Only thing is biometry is the longest time here, 130 seconds here in second trimester, and in third trimester it has 154. So what I would like to emphasize, if we follow a standardized 6 steps approach to start with, then we will have economy of movement. We don't have to randomly rotate the transducer here and there, because this is a very standard protocol, and we have observed by watching a lot of sonographers world over that they are also able to do these things very efficiently. So in ebook, all the 6 steps are written. Those of my friends who have received the ebook, you can again a lot of there, right? So I think this is what I would like
to. I have a
to
question whether you can answer, or Professor Khurana. In this particular table, the presentation and cardiac activity and placental localization, all these 3 points in the 6-step approach, why is it their NS not significant, p value is not significant?
Which one, which is not significant?
In this table you see that
right,
step 1, step 2 and step 4, that means presentation, cardiac activity and placental localization, it's all the rest are highly significant in the approach, but these 3 are not significant. Can you
Right.
explain,
Because-
Professor Furana, would you like to throw light on this?
It is the completion. This is the time taken. They are saying that this is the table to time to complete each step of the standardized 6 steps approach. This is the time interval, time what a candidate takes, you know. So biometry will naturally take time because we are measuring BPD as head circumference, femur length, and AC. And of course, I tell you, in biometry, all the except AC, the other 3 are bony landmarks. So they are comparatively very easy to obtain. But AC is challenging sometimes when we have less amniotic fluid, or sometimes when we have twins or there is less space, or the abdominal circumference is not completely round, it is oblong in shape due to some kind of pressure or sometimes. So biometry will take a little longer, but the all other steps have been completed in step 1, 15 seconds plus minus 8.7 seconds. Yeah.
Okay, thank you, Dr. Sunil. Thank you very much, Ajit. We will now move on to Professor Khurana's point. Khurana's reflections on this presentation and further enlightening the six steps. Professor
Yes,
Khurana, please.
thank you. Thank you very much. This has been so systematically presented. It was indeed a pleasure. Of course, we
Stop
will.
sharing, Ajit. Ajit, please stop sharing.
So you see, we must understand, of course, that we will in the future make sure that our internet connection is a superior one, so that we can all have the benefit of such an excellent presentation. You saw an extension of the basic ISWOG practice by straightforward everyday images from which you can benefit. The truly important part in today's presentation was the fact that you will cover 50 to 60% of what is required for good perinatal outcomes just by doing a basic scan. The remaining 40% for perinatal outcomes would be covered by doing the anomaly scan. So much can be covered in such a short time that it is absolutely marvelous. The important thing is that you have to follow a protocol and that there is no shortcut. If we go randomly, then you realize that you could still pick up number of fetuses, heart rate, and presentation, but you would take much longer on amniotic fluid biometry and the actual placenta. So we don't want to get stuck with that. And so we must go by step, both in the second trimester and in the third trimester. Also, there is the emphasis that there are routine basic scans, which is what you heard of today. And then there are specialized scans. So what we have learned today is the routine basic second and third trimester scan. And in the future, you will be exposed to how we do specialized scans. The specialized scan in the second trimester is the anomalies or the targeted scan for fetal anomalies. And in the third trimester, it is the growth and Doppler scan. And today was truly much more than just a lecture. It was a practical exercise, how best to go about this, and also the inclusion of images from everyday life. And it's been a real pleasure following this lecture by Dr. Ajit. And we'll be happy to answer any questions, but the reminder upon reminder, without a protocol, there is no success. Without a protocol, you can miss critical points. And in each ultrasound scan, irrespective of the number of patients, we must take out these 8 to 10 minutes to complete this basic work and then move on to what is specially required.
Thank you very much.
Thank you, sir.
Professor
Madam,
Khurana. Yes.
Madam, sorry to interrupt. Madam, some participants have requested for resharing the amniotic fluid index measure estimation PPTs.
Slide. Yes, while we do that, can we start the polls?
Yes, ma'am. We can check.
Let the polls be started and questions also can be, will you show the PPT of amniotic fluid or Ajit will show?
Dr. Ajit, can you share again?
Madam, poll questions are live now. Participants can
Please,
answer this. And
all of you,
meanwhile,
please
sir
attend the
can say
poll
at the.
questions. I hope you have listened very carefully to Ajit sir's talk. Now you can, I think you should be able to get all the questions right, which will be discussed after you have finished. Each one of them will be discussed by Professor Hasmukh Lal. In the meantime, you can also ask questions. Professor Khurana is there. You can ask questions while you are tackling the post polls. Please, all of you start answering the post poll questions. Do the post poll questions now that we have heard. All the 6 steps, 10 questions on the 6 steps. You could have had 50 questions, but we have boiled down to 10 easy ones. Please start answering, everyone. Please, participants, start answering the polls.
So on the screen, of course, on the laptops and on our phone screen, in the shared screen, we now have this excellent delineation of what the image should look like finally when we have computed the various 4 quadrants in the amniotic fluid index. And you've noticed that the measurements are done anterior to posterior in the 4 quadrants of the uterus, like it was emphasized, of the uterus and not of the maternal abdomen. We've also realized that in whichever abdomen there was a fetal part, in whichever pocket there was a fetal part or cord, then that has been excluded, and we've only included the truly amniotic fluid portion of the depth. And then we've added up all 4 quadrants and got a final answer of 12 centimeters. If we can see the actual slide before this, where you have shown us how beautifully we divide the uterus into 4 quadrants. If you could go 1 step back, yes, in a few seconds, I think that should come on. And yes, perfect. So this is how he has shown us clearly. The patient is lying down. In this image, we have a beautiful head, which is towards the top part of your screen. We have the foot end, to the bottom end of your screen. You have the foot end, which is to the top part of your screen. You can make out from the position of the examiner's hand and the patient's hand that we are looking at the patient from the foot end up, and the transducer is held along the longitudinal axis of your patient. Exactly as we heard in the presentation, we have beautifully placed the transducer vertically. It is not lying tilted, and it is placed in the 4 quadrants of this uterus. The upper on the right side, the upper on the left side, which is number 2, the lower on the right side, which is number 3, and the lower on the left side, which is number 4. During the actual real-time evaluation, we will realize that this may not always be a fixed position. It would depend on the number of weeks of gestation, and it would, of course, depend on the deepest pocket that you actually visualize. In order to visualize, when we move our transducer, we must make sure that we always hold the long axis of the transducer along the long axis of the patient, and that we don't turn it into a transverse axis. We must do it exactly as shown in this diagram, and only then can we be able to quantify this in a consistently reproducible and reliable manner. Thank you so much for these wonderful slides, Dr. Ajit. Any further clarification on this wonderful technique that we have now learned twice over today?
Sir, please tell about amniotic fluid measurement in twins.
So we have over the years developed different methods of measuring amniotic fluid, as you heard. In twins, we do not really have quadrants of the uterus because the fetuses are widely distributed. In dichorionic twins, we will measure the maximum vertical pocket in any part of the amniotic fluid, again holding the transducer in the same way as you see here, making sure that you exclude the cord, making sure that we exclude any part of the limb, and we will then calculate what is called either the deepest vertical pocket, the maximum vertical pocket, or the single deepest pocket. They all refer to the same thing. One single deepest pocket of fetus A and one single deepest pocket of fetus B. In twins that also have a single placenta and have two amniotic sacs, we will follow the same. The maximum vertical pocket of fetus A and the maximum vertical pocket of fetus B. In monochorionic twins, where you will have a single amniotic cavity, you will only have a single maximum vertical pocket. And these are extremely important because in monochorionics, of course, you'd like to know whether there is a polyamnios because that is a dangerous sign. In the dichorionics, amniotic fluid becomes extremely useful both for twin-to-twin transfusion syndrome evaluations of their severity, as well as in the evaluation of selective fetal growth restriction. So it's an extremely important part, even when we are considering twins, that we must estimate the amniotic fluid volume. When you become to a more advanced state, you will realize that you will be told several times that we assess the amniotic fluid only subjectively and say whether it is normal or not normal. Yes, there is no doubt that as you become an expert, you will say the amniotic fluid is normal. But for the sake of serial comparison wherever it is required, and to make sure that each one of us speaks the same language, which is the most important thing in biology, it is wise to quantify and wise to put it in the body of the report as well as to put it in the conclusions of your report. So very important part of the examination, the estimation of amniotic fluid volume. Here, for instance, is a deep pocket, and subjectively, I would never be sure of what it is, deep or whether it is polyamnios or not. And therefore, I would look to the bottom of my screen and find out what is the actual measurement. Note that the measurement is being done along a most perfectly vertical line. On the right-hand side of your screen, you will notice that there is a vertically oriented transducer. On the left side of the screen, you will notice that there is a perfectly perpendicular measurement. And you can see what beautiful slides we've seen this afternoon.
Thank you, sir. And
Thank you very much, sir. Narottam, hope that answers your questions about amniotic fluid in singleton. And hello, Narottam. That was
Yes,
you're in Ghazipura, aren't you?
again.
Ghazipura CHC, no? Hello, Narottam.
Yes, ma'am. Jasipur.
Yes, he's doing wonderful job.
Jasipur, Mayurvansh.
Jasipur.
Again, madam.
Jasipur, where Khairi was, Khairi, the tiger.
Garissa.
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
See, Professor Khurana, the benefit is going down right to the grassroots.
You know, it's not just my benefit. We formed such a beautiful team over here between the attendees and us. It is truly benefiting all of us. And it's an excellent revision for me. It's an excellent chance for the world to move ahead and for women to get the best perinatal outcome. I think we truly need to congratulate the entire team led by you for such a fantastic program being put together for the education of our peers.
No, you are the true leader, and Hashmukh sir is your brigadier. I'm just a coordinator.
You are the general actually for us.
Yes, and you know, there is such a beautiful curriculum put together by Hashmukh sir, and he has chosen the speakers so beautifully. Each one of them is explaining it at what I call the grassroots level. It's fantastic how the speakers are taking so much pains for such well-made slides, for adding on pictures that are used by workers in their everyday life, it's a fantastic combination. By looking at ideal pictures in a textbook, we will never get this kind of a experience of seeing how easy it is to do even when we are working on our basic machines.
So curriculum the jawab nahi.
Yes, absolutely.
Madam, shall I
Okay,
add some
yes, participants, you can unmute and ask. Padmalochan, why don't you unmute
Madam,
and ask?
shall I add,
Dr.
Madam, shall
Padmalochan,
I
please
add
unmute.
something?
Yes, yes, Ajit.
Dr. Padmalochan
Madam,
has
shall I
asked
add some
question.
pitfalls?
Pitfalls, yes.
Dr. Padmalochan
madam.
has asked AFI 4 at 14 weeks of pregnancy is severe oligohydramnios. That is his question, sir.
If I may answer that question, you see, when we look prior to about 18 to 20 weeks of gestation, we like to look at amniotic fluid in a subjective manner, and we also like to objectivize it. When we try and do an amniotic fluid index in a pregnancy that is usually less than about 14 to 16 weeks, the amniotic fluid index is difficult to quantify. And therefore we go more by the maximum vertical pocket, and we will not use a measurement just by itself. It must be combined with the amount of amniotic fluid that we see around the fetus. I use a rough index in very early pregnancy, and that of course is a first trimester thing. What we have discussed today and what Dr. Ajit has told us today is about the second and the third trimester. In the first trimester, we usually try and see what is the amount of amniotic fluid compared to the space occupied by the fetus. And as long as you can fit one more fetus into that uterus, you know that amniotic fluid volume is normal. If you cannot fit one more fetus into that uterus, that amniotic fluid index is low. And if you can fit in more than 2 fetuses, that again would be a polyhydramnios. So in the first trimester, we don't really like to use an amniotic fluid index, but in the second and the third, it is worth quantifying just as Dr. Ajit has taught us.
Okay, Dr. Padmalochan, that answers your question
I am not
brilliantly.
clear.
Yes.
Dr. Ajit was going to tell us about Dr. Ajit was going to tell us about the pitfalls of
Some
evaluation.
pitfalls, yes. Ajit.
I'm looking forward to that.
Madam, while estimating the amniotic fluid, there are certain pitfalls. Number one, if you do excess probe pressure, the amniotic fluid volume will decrease by 21%. That's very important. So excess probe pressure should not be given, number one. Number two, if the fetus is placed centrally within the uterus, then the amniotic fluid will be less if the fetus is placed lateral to the uterus. So centrally placed fetus, amniotic fluid may little bit less compared to laterally lying fetus. So fetal position.
Disturb
fetal, so study have shown the AFI was 4.35 centimeter higher for fetus lying centrally within the uterus compared to fetus lying laterally in the uterus. So in these cases, you have to do single deepest vertical pocket. Number 3, as we know, obesity significantly reduces the fluid because of the fat which scatter the ultrasound beam and introduce artificial echoes. In these patients, we have to use lower frequency transducer. So in case of obese patient, to underestimate or overestimate the amniotic fluid, we have to use lower frequency transducer. Number 4, in case of free floating particle like scabious, they make true amniotic space less conspicuous. So these are the 4 important things which we should be aware where measuring the amniotic fluid volume. And another study they have seen the amniotic fluid amount, if it is less in the lower quadrants compared to upper quadrant, then there is increased chance of fetal distress increased chance of deceleration in terms of late deceleration or variable deceleration, and increased chance of decreased score, and increased chance of neonatal admission of the newborn. That means if we are seeing less amount of amniotic fluid pocket in the lower quadrant, then chance of fetal distress is more than if the fluid is more in the lower quadrant. These are the important things which I have highlighted. Any observations, sir? Professor Khurana, sir?
Now,
I
there's
would-
another question,
I
Ajit.
would fully agree with you.
Yes, yes. I hope everybody has taken in the points given by Ajit. And Gitanjali Das is asking if there is AFI 3 in a 28-week fetus, what do we do? Isn't it?
Then we have to take the history, madam, whether it is due to leaking or whether due to the renal agenesis or any anatomical cause. If it is due to leaking, then of course
No
there
leaking,
is
no leaking,
any
no
renal
leaking.
abnormality. No leaking, then we have to go for the survey. We have to find out the kidneys are there or not. It's the most important thing to rule out if AFI is 3 in very early pregnancy. I think it is so.
Yes, I think one
Khurana
should
sir will
do blood
describe in
flow.
detail, I think.
Yes, Ajit. Gitanjali, I think one should do blood flow studies here.
Yes.
And there is, if you don't find any other cause, you do, we can give, you hydrate the patient, give rest on flanks, deep breathing, and you can give human albumin infusion. That is one substance which will increase the amniotic fluid when no other, the cause is found. So everybody should know that human albumin infusion in oligoamnios, severe oligoamnios, it does help. At least in my practice and in the medical college when we were working.
Yes, madam, it's very useful. It's useful.
Human albumin is the fluid or substance which will increase the AFI.
Amount of the fluid.
And so all these specialists must know, if you see this kind of thing, and you have to exclude other factors also, you have to give human albumin, including rest, including deep breathing, which increases the physical solution of oxygen and reduces fetal hypoxia. And she should lie on flanks, more rest, and hydration also.
Madam,
And human
madam,
albumin
a
is also,
single infusion is sufficient.
no, you see, you can give 2, 3, no problem. See, I have seen AFI going from 5 up to 12 by giving at least 4 albumin infusions.
Interval, madam?
At interval of?
You can see, you can take an interval of 3-4 days, see the AFI.
Okay.
Twice a week. Twice a week.
Vilas Das is asking the doses of albumin.
Human albumin is 5%, human albumin.
Okay.
So twice a week.
Sir, can I ask one question, Ajit sir?
Yes, yes.
Yes, Professor Khurana, opinion on albumin also I would like to know.
Yes.
Can I, sir?
Yeah.
Yes.
Yes.
Sir, what is the role of indomethacin in case of polyhydramnios, sir?
Yeah. If patient is having embarrassing symptom or respiratory discomfort, then we are giving indomethacin.
So what is the dose? Can you please tell me? I have never used.
Indomethacin SR 50 BD.
Sir, 50 BD, okay.
Yeah.
But there's a
then we have
chance
to
of
stop.
early closure of ductus arteriosus, so be careful.
Yes, that has to be looked into.
Okay. Okay, sir, got it. Thank you so much.
Monitoring is required for ductus arteriosus blockage. Yeah.
Yes.
Mhm.
And for the
That we have
oligoamnios.
to send to hospital, sir.
Yes, Professor Khurana wants to say something, please.
Yes, what I was mentioning was that when we assess for oligoamnios and we have excluded leaking, the next most common cause, of course, is a placental insufficiency and growth restriction. And we must also look for, as mentioned already, we must look for urinary anomalies, either renal agenesis or an obstructive uropathy in the urethra or bladder. And the third very common cause is an intrauterine infection. So if you find oligoamnios, then you must look again for for findings in the placenta and the fetus for intrauterine infections such as fetal fluid collections, fetal visceral calcification, fetal cardiac anomalies, ventriculomegaly, cataract, and placental size. So that is very important to make sure that you're not missing a very serious cause of oligoamnios with a poor prognosis, because intrauterine infections have a largely poor prognosis.
If there's an intrauterine infection, what do we do?
Then we have to investigate completely and find out what is the type
What's
of
the
intrauterine
sensitivity of
infection.
amniotic fluid?
So by itself, amniotic fluid index would not mean very much, but you'll have to go through whether this patient has ever been evaluated for her cytomegalovirus or toxoplasmosis, whether she has ever had any serial evaluation for that, and whether there are any associated signs. And otherwise, of course, you might even require an amniocentesis to assess, which is very tricky because it is already less amniotic fluid, and we have a high chance of a fetal demise. But it's nice to go over the entire clinical picture, find out of a history of rash, etc., because rubella, cytomegalovirus, and toxoplasmosis, all three are associated with less amniotic fluid. And then there is a very nice, straightforward clinical question on whether there is any relationship between AFI and fluid amount and volume. And so therefore, we must understand that all of these things that we have spoken of today are directly related to the amniotic fluid volume. And therefore, we are using them as indices. So the deepest vertical pocket, as well as the amniotic fluid index, are related to the amniotic fluid volume, but the volume is difficult to calculate because even 3D is not efficient in doing so, and therefore we use them as an indicator of amniotic fluid volume. Of course, there are people with even in our own group where we have such a reasonable amount of clinical acumen that just by putting up our hand on the fetal abdomen, we can say, yes, there is increased LICA or decreased LICA. But ultrasound takes you into a more objective evaluation of what is going on over there.
Sir, Gitanjali Das is asking, is TIFA scan can be done at 28 to 30 weeks?
Yes, there's a routine anomaly scan, which is the scan done at 20 weeks. Previously in India, we were doing them earlier because we had a deadline for 20 weeks for termination of serious defects. Now we have changed that deadline to 24 weeks. Change the deadline in the sense that two qualified physicians need to sign the paper for a termination of pregnancy for an anomaly up to 24 weeks. And that is the time that we do the standard TIFA scan. However, at any time of the pregnancy, if you have a suspicion for an abnormality, you can carry out a full detailed scan for anomalies. This does not get restricted whether you are 26 weeks, 30 weeks, 36 weeks, or 39 weeks. Yes, the visualization of fetal anatomy gets restricted as the fetus grows because of the fetal position. It goes into a fetal position of flexion. It gets restricted because of ossification of the skeleton, so you can't make out very much within the thorax and abdomen. And of course, these are the limitations. But at any time when you suspect a problem, you can always do a TIFA scan. The routine TIFA scan, of course, is done at 20 weeks of pregnancy.
The later we do, there will be more visualization become difficult because of bony ossifications.
Yeah, yes, and fetal position. Yeah. So that attitude flexion will interfere with visualization.
There is another question from Sanjay Rai. Particles floating in amniotic fluid, is it meconium?
This is a very good question. I like this question very much. There are several particles that can float in amniotic fluid. You can have vernix, which is just the skin being shed off. You can have blood. You can have meconium, and you can have pus. And you cannot tell the difference between any of these. So you have to look for indirect signs of these, but particles are not necessarily meconium. They could be completely normal 1x.
So in a TIFA scan, it should be absolutely clear. In early weeks, if there is
Truly
meconium,
speaking, yes,
like
but
a
we have
stain, which
realized,
maybe
yes,
blood.
but we have realized that as technology has advanced, we are picking up more and more smaller particles within the amniotic fluid because of high resolution transducers. So a diffuse increase in echogenicity within the amniotic fluid would not worry me anymore. It always has to have a clinical context.
Yes, yes, yes.
Ashwini Vishwanath is asking which one is more specific, AFI or SDP? I think he's asking about the vertical pool. As what is
Single deepest pocket?
Single,
Yeah.
single deepest pocket. Okay.
Yeah. So we know that none of these is a perfect index of amniotic fluid, and therefore we've had to choose. It's really a matter of debate over the years. When we started with single deepest pocket, we were told no, amniotic fluid index is better. When we moved on to the index, they said no, it is better to do single deepest pocket. So this will remain a controversy. What I like to do is that I make sure that I survey the whole uterus, that I check out all the pockets, decide for myself subjectively what is going on. And for the purposes of comparison, I will always in singleton pregnancies do an amniotic fluid index.
Now go for, shall we now end the polls, Sambit? And
Yes.
we'll discuss the poll questions.
Again, madam, madam, out of 99%, 66 only have responded. If the discussions are over,
Why?
then we can close this poll questions.
I think
We can go ahead with the poll questions.
so. Unless you end the poll, we can't discuss the answers.
Yes, ma'am.
So we can end. We'll have to be satisfied with 66%.
Everyone has answered already.
Only 66% have answered.
Oh, but today's topic is very, very interesting, and I think they should all have attempted. Everybody should have attempted at least.
You need some more time, 5 minutes more for more to attend. Hello?
Ma'am, I have already.
You ended the polls?
Yes, ma'am.
Okay, then. Then we'll discuss the questions.
Right. So the first question is obstetric ultrasound is inherently difficult due to, I think all of the above is the right answer, because fetal, as Ajit sir has already told, that the anatomy is complex, then shadowing is one aspect, maternal body habitus. I mean, it's a day by day we are facing this problem, and nobody will be sympathetic to us if we miss something. So all of the above is the right answer.
So what is the difference between pre and post poll, Sambit? I think
Madam, the difference between madam, the difference is very minimal. It was the correct response was 91% in the pre-orientation poll, and now it is 98%.
So 7% improvement.
7% improvement.
Somebody still keeps thinking that maternal habitus is the only reason. Okay, next question.
Next question is 6-step sequence of second and third trimester USG examinations are. So I think these 6 steps are very systematically described already. That we saw that first part was the presentation, second is the cardiac activity, number of fetuses, placental localization, amniotic fluid volume, and biometry was the last. So I think D is the correct answer, and 74% people have answered to that.
And sir, there is a significant improvement from 27% to 74%.
Good.
Pre-orientation.
Very good. Needs a clap. Good. Participants have done well. You have listened to Ajit sir, and Ajit sir has delivered well. Next question.
Yeah. So the third question is for fetal presentation and light. as I think this is I also told about the principle of physics, that 90-degree. And at this point of time, there are a lot of other maneuvers of transducer like rocking and sliding, but then those things are applied later on and not at the beginning stage. So for present state, I think the B is the right answer. The transducer is kept transversely in the lower abdomen, just above the symphysis pubis. It is transverse. Only when we measure the amniotic fluid, the transducer has to be in sagittal direction. The direction is changed. And transducer, as I would like to emphasize, I think this point was already told, we never rotate the transducer more than 90-degree. You know, there is a notch. The notch is towards patient's right. And when we rotate, when we
All these things will,
Yeah.
on-site visit, all these things
Right.
will be clarified.
will be clarifying.
And sir,
So
there is a improvement from 40% pre-orientation poll questionnaire to 85% in this.
Very good. Again, this is very satisfying. Thank you. Good participants. Congratulations.
yeah, thank you. So number 4 is for detecting the cardiac activity. The transducer has to be in transverse position just above the symphysis pubis and is moved in the mid-abdomen towards the umbilicus, maintaining a transverse orientation. A is the correct answer.
And the difference is from 48% pre-orientation poll questionnaire correct response to 77% post-orientation.
Again, very good. Very good job.
Yeah. Number 5, to scan the number of fetuses in part 1. In part 1, that is to scan the number of fetuses. A is the correct answer. Uterine cavity is viewed with transducer in transverse orientation from below upwards. You know, from symphysis pubis towards the fundus, in the right, then mid, and then to the left side.
And the improvement is from 45% to 58%. Pre-orientation.
Reasonably good. Next question.
Number 6, for location and position of the placenta, there is a single choice. The transducer is held sagittally and moved from fundus to symphysis pubis on lines 1, 2, 3. That is the correct answer. B is the correct answer. And Ajit sir emphasized on that in others we are going from below to up. For placenta, we are coming from fundus towards symphysis because we need to see the end of the placenta, where placenta ends, the attachment, lower end of the placenta we have to see. So that is the right answer is B.
And the improvement is from 47% to 70%. Correct.
Good.
response.
Number 7, for estimation of the amniotic fluid, the transducer is held sagittally in 4 quadrants. So D is the correct answer, and 82% of our friends have replied right.
There is an improvement from 60% during pre-orientation questionnaire to 82%.
Thank you.
Good improvement. So people actually,
Number 8, what are the fetal biometries done in 2nd and 3rd trimester ultrasound? So already I think Ajit sir elaborated on 4 points. We have to do BPD, then we go for head circumference, then we go to abdominal circumference, and then we go to femoral length. And I think when we do on-site with one sliding movement, Ashok sir does it with one sliding movement, all the 4. Sir, in one sliding movement, Ashok sir will complete all the 4 from BPD, SC, AC, and then FL.
Here actually, I'm
He is the right
reminded when I was, when we went for Suresh's training, his assistant told us that if you don't get the BPD, you go for the spino occipital
Neck.
angle. From there, you give a round sweep and you come to the BPD plane.
Right.
Remember, because they used to teach us like that.
Yeah,
Go to
we
the
were taught to
Because-
go to the neck, see the
Neck first.
posterior part of the neck and rotate 90 degree. We will go to the, he had a nice book also published on how to manipulate the probe about it. Yeah. So
Jump.
I will go to Ashok sir's training.
So what was the pre
learn a lot of things.
pre-pole, post-pole difference?
Madam, the pre orientation poll response was correct response was of 88%, and now it has improved to 95%.
B is the correct.
7%. Because everybody knows this.
Yeah.
Somehow. Anyway, next question.
Number 9, first, what is the first biometric measurement we take in second and third trimester USG? Yeah, we already told that BPD is the first one. So A is the correct answer.
And the difference
Still
is from
some think that it's not
77.
the first one. 2-3% think it's not the first one. Okay, what was pre and post-pole difference?
Madam, pre to post poll difference is from 77% to 92%.
Oh, it's good.
Pre and
So that means there were quite some who didn't think that BPD was the first measurement.
So we will settle for
Good.
yes. In room
Next,
number
last question.
Number 10, which one should not be seen while imaging the proper abdominal circumference plane? And Ajit sir has emphasized this, that we never see fetal kidneys and urinary bladder in AC circumference, and C is the right answer. Fetal kidneys and urinary bladder should not be visible in the plane where we measure abdominal circumference. When Shyama madam was telling that sometimes we see the suprarenal gland, that particular thing is acceptable. If it comes, we can't angle beyond to avoid that. So sometimes we see suprarenal, and that measurement is very, very nearer to the perfect abdominal AC plane, isn't it, sir? Ashok sir will be more.
I fully agree with that. Yes.
So,
That,
even
always the adrenal is the best indicator. Yes.
right.
Suresh used to tell us rice grain-like appearance. I remember that.
And there also you
Adrenals-
can see the lying
adrenals
down.
look like rice grain.
Renal or absent. So C is the correct answer, madam.
And madam, there is a significant improvement in these questions also, from 56% during pre-orientation poll questionnaire to 94%.
Great. But it's also encouraging that 56% knew that kidneys and bladder should not be measured.
Yeah, and of course, in the next presentation is by Dr. Josna Rani, where she is coming up with fetal biometry and other things. So again, this fetal biometry will be repeated once more by her.
From a different angle. No?
Yeah, of course.
And like CSP, Professor Khurana, if you don't see the CSP in second trimester, it means that there's corpus callosum agenesis.
Absence of
Corpus callosum.
It's a very good, what we call a proxy marker for corpus callosum. The corpus callosum is difficult to visualize in routine evaluation, and the visualization of the cavum septum pellucidum is an excellent way for confirming the presence of a corpus callosum. Of course, very occasionally there can be exceptions, but in general, if you see a good cavum septum pellucidum, you will always see a good corpus callosum. No doubt about that.
And as I think holoprosencephaly can be excluded right in first trimester itself, if we don't see a midline fox,
That's right.
then it is a holoprosencephaly. Yeah. So anyhow, I think the topic went very well, and Ashok sir, thank you so much for all your guidance.
Pleasure.
Thank you very much. And
I clarify
many valuable points by Professor Khurana. like fetal infection and other markers in oligoamnios. So we have to differentiate between also Potter's syndrome, Potter's syndrome,
Yes.
where absence of kidneys, and also when there's gross oligoamnios with the presence of kidneys. The prognosis.
Wonderful. This is really an excellent program today. Really very well done. And I look forward to next Friday.
Yes, thank you.
Yeah.
Thank you, everybody. Any participants still? Professor Khurana is still there. If you want to ask any more questions before
Madam.
he leaves, we've taken so much of
Madam.
his valuable time. Yes, Padmalochan, go ahead.
Madam, I have a question.
Yes, yes.
Madam, what is the minimum transverse diameter in measuring the AFI when we are taking the vertical diameter of so much length?
Transverse
And in-
diameter.
What is the minimum transverse diameter should be there to take the vertical diameter in a pocket? Otherwise,
I don't know.
There have been some studies and they do mention that we should measure the maximum vertical pocket in 2 dimensions, in a vertical as well as in a transverse. And in between for a few years, we did do that. But we found many more studies that came along that said that it did not improve the interpretation. And so we said that if you are seeing it, we will no longer pay attention to the transverse diameter.
Nice, sir. My question is, when we are taking the vertical diameter, in some plane the transverse diameter is 4 centimeter, some plane is 1 centimeter, some plane it is transverse diameter is 10 centimeter. So what should be the new transverse diameter where we take the vertical diameter of the fluid?
It's not important anymore. It can be 1 centimeter, 2, 3, 4, or 5. It doesn't matter. We should just stick to by itself the actual vertical distance that you measure.
Because in 10 centimeters of transverse diameter and the vertical diameter is 10, so it is volume is so very high. But if the transverse diameter is only 1 or 2 centimeter, vertical diameter is 10 centimeter, the fluid is very less there.
Yes,
So,
but when you take an index, then that will be overcome.
We have to add all the 4. We have to add all the 4. And I think, sir, Ashok, sir, what is your opinion about sometimes when we see in one pocket anything which exceeds 8 centimeter, you know?
Yes. So I attach importance to that anything that exceeds 8 centimeters in one pocket and anything that is less than 1 centimeter, and there is a general subjective evaluation, then I would attach importance to that also.
The smallest one is 1 centimeter or 2 centimeter?
We've shifted to 1 centimeter in recent times. Yes.
okay, sir. Thank you.
So normally we have a tendency, if we can't find a pocket, we tilt the transducer and try to look for one pocket in any case and measure it.
Yes.
So that is a
one of today's best lessons is not to tilt when we are doing that measure.
yeah.
Yes.
Actually,
But then desperately we want to see there's still somewhere.
but then we are writing sometimes when we don't find anything, I write virtually none.
Yes.
So if you
that's a
cannot
beautiful
find
word. Yes.
any, virtually none. Yeah.
Yeah. I use the same phrase myself.
Yeah. I have learned from you, sir.
So we'll be using this, all of us will be using this term henceforth.
Yes.
And all trainers also must, during the on-site visit also, take these messages down. So we will have Professor Khurana's blessings and presence also, subtle presence when all of us go down to the districts.
I look forward to that myself.
We can even contact you over phone if we find some problems which we cannot solve.
Oh yes, absolutely, absolutely. There's no problem.
Thank you so much.
Yes, with pleasure.
Thank you, ma'am. Thank you, sir.
When
Thank
these
you.
things happen, it's
Namaskar,
actually
namaskar all.
somewhere somebody is blessing from above is arranging all this. Thank you very, very much.
Thank you so much for a lovely session. Thank you very much.
Thank
Namaskar.
you so
Bye
much.
bye.
Thank you.
Thank you, sir.
Thank you. So,
Madam,
regarding this,
session end कर दे भी है.
no, just wait. Regarding
Okay,
that proposal, you have to give me today.
मैडम आज मु प्रपोजल ड्राफ्ट कर दउची मैडम काली
Draft
मीना
करके-
मैडम और डॉक्टर बजेश को संगे आज्ञा डॉक्टर बजेश को संगे रे मु प्रिलिमिनरी डिस्कशन कर देगी तापरे आपण से शेयर कर देबी और
So,
एनएचएम सरोज शेयर कर देबी.
I'll, I think I'll talk with MD.
आगे
so
मैडम
that
आपण
he
एमडी
gives us
मैडम को
some time, 1 or 2 days. Can we go down to her office on Monday?
आगे मैडम मैडम मु भुवनेश्वर अछि तो आपण जबे भी कहबे मु अवेलेबल अछि तो
I'll ask her whether she, if she thinks that we can go down, or we will send a mail with the proposal. And
मैडम
we'll-
बेटर ये हबो जे हमें प्रपोजल गोटे हार्ड कॉपी नै कि ता फेस टू फेस डिस्कशन करले मैडम बेटर आउटकम रहेगा.
Okay, then.
मैडम आपण टाइम नै जानतो बाकी मंडे न तो मु अछि.
ମୁଁ ଆଜି time ନେଇଯାଉଛି. Time ନେଇଯାଉଛି. And,
Thank you.
Saroj, please, you are in the NHM office. You also put in a word to the MD so that Saroj has left, right? He has left. Anyway, he's a big catalyst. He will help us. We must definitely, we have very little time. We have to contact. Once we get it done, we will have a Zoom meet, Hasmukh sir, with all the trainers.
Right. And today I think I am going to put it in our group that
Yes, put in the group.
who is taking
So,
which district.
Yes, which districts would be convenient for
Again.
them, and which days also. Day is important. Leaving out holidays, which day would be convenient for that particular trainer?
Okay.
Day and district.
Right.
So when that is ready, we will communicate that also. Sambit is in that group, he will know. Both Sambit and Saroj are in both groups. They will know which dates.
Ajit sir is Ajit sir eta आपण को district ता नहीं पारिबे.
मैडम जो सजेस्ट करिवे
नहीं मु कोची लेडीज मानु को पाखा डिस्ट्रिक्ट दियो. प्रीति
किछ
दुबे.
प्रॉब्लम नहीं मैडम.
So you take Bhadrak or Balasore, Amitabh will take.
Amitabh is
And,
there.
मैडम हमको प्लान बी भी रखियो पड़िबो जदी फैसिलिटेटर 1 जदी कोनसी अनअवेलेबल सर्कमस्टेंस पे कंसर्न डिस्ट्रिक्ट को सेम डे रे जाई न परिबे त ताले तांकर
हां स्टैंड बाय जणे रहबो.
प्लान करियो पड़ो.
हां स्टैंड बाय जणे रहबो.
Actually, I like the idea which Dr. Pramodini gave. For example,
दीदी जणो को पोस्ट कले भलो.
दुई जन in the sense देखो मु और Samrendra both we are covering 3 districts. So I will also go. Samrendra is accompanying me, so it is not a problem because
Yes.
Panipatna.
2 trainers will be good.
Yeah.
One day
Actually,
somebody will be discussing,
Navapara,
another person will be demonstrating.
Navapara. These 3 places I can.
Okay then.
मो सहित मैडम आमर जो आउ जने अछंती प्रोफेसर अछंती एम्स रे अछंती रायपुर रे. When I was just talking that we have started this program, then she said, okay, you call me, I will come and do on site. I will come and teach them. She is willing to come.
See,
Yeah.
our district administration has to allow another.
No, she is not asking for any cost actually.
No,
She- ତାଙ୍କର କିଛି ନାହିଁ. It is just a interest. For example, I am also not keen on that what you give me or not. I mean, it is not very
None
important.
of us are, but
I can take my car and go. And this is not difficult actually. So, एमती का किसी नहीं जे we are not doing it for money actually. That's not very important actually. आपनकर दयारु आमे भगवान आपण देइछंती बहुत हमको.
एई के कहा दया नहंती सबु दया गोटे लोक ऊपर वाला करे. It is our privilege to participate in a great work.
Nice.
We are all together. We are all enjoying it, and
I think the program has to be so, we have to make it so interesting that everybody should be waiting for Friday, you know. So
I think it's taking a shape because a lot of people joined even before the sessions. It went up to 127 participants.
Ajit sir performed excellent. Aji apan bahut
Yes,
badhiya apan
बढ़िया, बढ़िया clear.
Thank you, sir. Thank you, madam.
Since postgraduate, he has been trained in teachers training. In JIPMER, postgraduate students
No, no,
also
also-
undertake the NTTC training, isn't it?
ଆପଣ ତ କଟକରେ ବି ପଢଉଛନ୍ତି ନା, student ମାନଙ୍କୁ ପଢଉଛନ୍ତି, already he is teaching, so yeah.
His base is JIPMER. So in JIPMER, postgraduate students also undertake teaching teachers training course. They also have to teach the undergraduates, and they have to give their fee. That way they are also evaluated. Okay.
Thank
So
you.
Sambit, shall we end the meeting? Thank you very,
ଆଜ୍ଞା
very
ମ୍ୟାଡାମ
much.
ଆପଣ କହିଲେ ଏଣ୍ଡ କରିଦେବା ମ୍ୟାଡାମ ଖାଲି ଆମକୁ ଆଉ ଗୋଟେ କିଛି ମେକାନିଜମ ଆମକୁ ବାହାର କରିବାକୁ ପଡିବ ଯେ ପ୍ରି ଆଣ୍ଡ ପୋଷ୍ଟ ଓରିଏଣ୍ଟେସନ ପୋଲ ରେ ଯେମିତି ମ୍ୟାକ୍ସିମମ୍ ପାର୍ଟିସିପେସନ ହବ ଆରାଉଣ୍ଡ ସବୁବେଳେ ଆରାଉଣ୍ଡ 70-60% ପାର୍ଟିସିପେଣ୍ଟସିପ ପାର୍ଟିସିପେଟ କରୁଛନ୍ତି ବାକି ମାନେ as soon as the session ends they log out.
ଆମେ ମୁଁ ଭାବୁଛି ଆମେ ଏ ଯୋଉ poll question with right answer ଆମେ group ରେ ଦେଇ ଦେବା କଥା, so that even they can be familiar, at least that adds to their knowledge actually.
ଆଜ୍ଞା sir ମୁଁ ଦେଇ ଦେବି ଆଜ୍ଞା.
No, they should hang on when the questions have been discussed after the polls. That is the time they should they usually hanging on till then. Majority thile when the questions were being discussed. So you
Sir,
can
actually
take
जो
the horse
हमारा-
to the water, but you can't make it drink.
सर हमर जो लास्ट वीडियो रिकॉर्डिंग गुडा को अराउंड 2 आवर्स ड्यूरेशन रही तो सेट पे सेटा बहुत वॉल्यूम रही तो गूगल ड्राइव रे एते स्पेस नोनी तो ताकू हमें गूगल ड्राइव रे शेयर अपलोड करिया पे चेष्टा करथलु तो गोटे दिटा अपलोड हे सरला परे बाकी इनएडिक्वेट स्पेस पे ड्राइव रे भी हे पलन तो हमें भी करछु मैडम YouTube रे जो RRC रा हमर YouTube लिंक अछि सेतरे YouTube रे शेयर कर दोछु तार लिंक ता खाली से फोल्डर रे रखि दो.
हाँ ठीक हो, that's best. YouTube link रे दे देले भलो. It remains for all times.
And with all PPTs also.
Sambit Babu, tell me one thing. Let us say if I want to have something, can I have it on a pen drive or something, you know?
Again sir आपण pen drive रे नहीं करिवे
नहीं
नहीं
पाइबा
सर ई थ्रू ड्राइव रो डाउनलोड करी कि ना केमती.
अच्छा, I think you know those of our friends, they can take it on their pen drive also, you know, because it's a good content. I mean, lot of information is coming up,
Especially the discussion part.
discussion
also-
part
सर आपण जदी परमिशन देबे मैडम जदी परमिशन देबे ताल WhatsApp ग्रुप रे भी हमें पीपीटी गुडा को जो हमरो ट्रेनिंग्स माने को जो WhatsApp ग्रुप है सेतरे भी शेयर कर दो.
हां दे दियंतु किसी असुविधा
PPT
नहीं.
गुड़ा दे दियो. PPT
आज्ञा.
गुड़ा दे दियो, किंतु जो discussion part टा they will be.
Data they will miss until unless they listen to the video recording.
से वीडियो टा YouTube लिंक रे दे देले से माने YouTube रे देखिबे तांको निजो सेट रे they can download it. नहीं
आगे मैडम आगे.
तांको लैपटॉप रे हो बा डेस्कटॉप रे हो से माने किबा मोबाइल रे डाउनलोड कर दे कि ताको ट्रांसफर कर देबे टू हार्ड
Madam,
डिस्क.
if they want, they can download it. But आमर जेहेतु आमर regional resource center जो कोरापुट जो सही लक्ष्मण नायक मेडिकल कॉलेज रे हेची तो सेटा सेटे तार अकाउंट रे अछि तो सेटा irrespective of आमे आजी माने मु यूनिसेफ संगे थाई बा न थाई बा अलग की आसनु तो that content will be there with the link. तो तेनु सेमान सब बेले it will remain forever.
आपण हां
चाहिले
YouTube
person
रे भी देकरी लिंक देबाटा भलो हेबो. That is a good idea.
आगे सर.
YouTube रे हां
YouTube लिंक रे समस्त एक्सेस कर पेले.
right.
आगे मैडम.
Very easy.
हां हो आज का टास्क बहुत ये you have to sit for hard work Sambit.
आगे मैडम मैडम आज ड्राफ्ट ता प्रिपेयर कर दो आगे.
कर दियो मैडम को
proposal
टाइम मागी दबा यदि पॉसिबल on Monday. Tomorrow is too early. Tomorrow you talk to
Tomorrow-
Meena and
आगे मैडम हाँ प्रिलिमिनरी डिस्कशन मैडम कर दउची मीना मैडम और ब्रज सर
Contact
संगे
with me, मो कोन मैडम कहउचंती हसमुख
आज्ञा।
सर को भी मु कहि देबी
आज्ञा।
कोन करियो हबो हसमुख सर को टास्क हला आज समस्त को पचार देबे को डिस्ट्रिक्ट प्रेफर and which particular day of the week they prefer. See preference भी हमरो we have to keep in mind.
मैडम आमे एक्सपोजर को मैक्सिमाइज करिया पई आमे वीक टा सेया ही रखिबा 9th of every month थ्रू अप टू 12th बा 15th भितरे नेक्स्ट वर्किंग डे जेबे होतो कन्वीनियंस अनुसार पार्टिसिपेट मन जाय परबे सो दैट आमे डिस्ट्रिक्ट रे जत्ते हमरो हाई रिस्क प्रेगनेंसी हो बा नॉर्मल हो जहां भी पीएमएसएमएल जो माने आइडेंटिफाइड हेबे ताकू लाइन अप करके सेम डे रे आमे मोबिलाइज करि परतबा डिस्ट्रिक्ट हॉस्पिटल को
हां ठीक अछि अमिताभ सर अछंती अनम्यूट करनांती
Amitabh, yeah, actually say
अछंती is still there. Rama Manjri is there.
Amitabh Giri. Amitabh Giri.
Baske had come for 7 days training. Abhipsa, did you attend the whole thing? Did you attend all the questions? Abhipsa, she is our assistant professor in SCV. I don't know